All right, good morning, everyone, and welcome to week 3 of Orick Safe Del Norte's Wellness and Recovery series. My name is Malaya Florendo, and I'm the trainer with Orick Safe Del Norte. Thank you all for joining us this beautiful Thursday morning. We thank you all for jumping in, whether it's on Zoom or Facebook Live. We do want to remind everyone, if you are on Zoom, please keep your selves muted and your video off out of respect for our presenters today. If you are on Facebook Live, please remember to, you're totally welcome to leave comments and questions, and we have someone monitoring the chat. So if you have any questions, they'll try to get to them as soon as possible. There is about a 45-second delay, so we do just want to keep that in mind for all of our, everyone watching out there. And for those in the Zoom, you are also welcome to leave questions in the chat, and we'll make sure to write them down so we can get back to them later. So we just want to say again, welcome and thank you for being here. Today we'll be going over the What is Pain workshop with our presenter, Tim Connell. Tim Connell is the pharmacy director with United Indian Health Services. And I'm going to hand it over to you, Tim, to introduce yourself. And I believe you're on mute.
Hello, everybody. Glad to be here today. As was said, I'm Tim, or Timothy Connell. I'm a director of pharmacy at United Indian Health Services. Just a little background: I was born and raised in Santa Barbara, California. My father was a professor of biology at UC Santa Barbara and kind of a world-renowned ecologist. My mother was the first mayor of Goleta when it became a city, and he's a political and social activist. So very proud of where I came from, my roots. I'm married. I've got 3 children, ages 33, 31, and 29, 3 grandchildren, and 2 on the way. So we're very excited about that. That's me. I think I turn it back over for a little bit for your disclaimers, and then we'll get on with my presentation.
Yeah, awesome. Thank you so much, Tim. We appreciate having you today. Awesome. Well, before we get started, as always, we will go over some group agreements for everyone in the group today and watching. We do always want to keep in mind that respect and kindness are key. If you're not being respectful and it becomes a persistent issue, we will have to remove you. Please show tolerance and sensitivity for differences. Participants in the group come from different cultural, racial, gender, and sexually oriented backgrounds, so please be aware and sensitive to judgmental comments. Use positive language and stay away from using racial, homophobic, and degrading remarks if possible. This is a safe space and it is free of judgment, and it's totally all right to disagree with someone else's point of view. However, we just don't want to put each other down for it. This is a space where participants should feel comfortable to be themselves, share thoughts and ideas without any worry of punishment or judgment. For those sharing stories, if participants are sharing personal information, they should leave specific names out of their stories. If you are going to share a story about someone, you can say, I know someone, ... because using names often aids in the spread of rumors and detracts from the point of the information trying to be communicated. If you are confused or you have any questions, please ask for clarification. If you don't understand, you're totally welcome to. Again, this is a safe space and free of judgment. Don't be afraid to ask any questions if you don't understand the information provided. Again, you can ask questions in the chat here on the Zoom, as well as on the Facebook Live. And I just want to say thank you everyone again for joining, and to please respect our group agreements as we go through this presentation. Also, sometimes in these presentations, we do have some conversations that may bring up some feelings or emotions or concerns. And so if that does affect you, or you do get those feelings or concerns, don't be afraid to reach out and ask for help. Sometimes heavy topics can come up, so if you need to talk to someone, please reach out. We have the Mental Health Del Norte number here. as well as the 24-hour crisis services that are available. Again, if you are feeling trauma or triggered from some heavy topics that may come up in these presentations, you are welcome to reach out and try and find help for that. As far as our informed consent and privacy, each person's participation in this presentation is voluntary. Please respect the privacy of others and do not share personal information with anyone else. This training is being recorded and is live on social media, so if you are participating via Zoom, please turn your video camera off and stay muted. We always want to acknowledge the land that we are meeting on virtually. We are meeting across many indigenous lands, such as the Tolowa, Diné, Yurok, Karuk, Hupa, Wiyot, and many rancherias such as Elk Valley, Resigini, Big Lagoon, Trinidad, Blue Lake, Table Bluff, and Ronerville. If you don't know which area that you are watching from, it doesn't hurt to do the research and just try and acknowledge the land that you're on today. We honor the indigenous peoples who lived together and cared for this land and each other since time immemorial. We honor with gratitude the land itself and the people who have been the stewards of this land for generations. We know the effects of colonization have impacted indigenous people disproportionately, and we hope that through this series we can learn together to help heal and work towards a healthy future. All right. So now I'm going to pass it back to Tim so he can start his presentation on what is pain.
All right, everybody. Hopefully it's my presentation up, right?
I think you need to share your screen.
Does that show now?
No.
I hope. Am I sharing my screen?
No, I'm not seeing it pop up yet.
That's bad. Really? I don't have my screen up. Oh, that's one.
There you go.
Cool.
Thank you.
IT is wonderful.
Right?
Those guys. All right. Excuse me if I read my slides to you, but it helps establish the baseline for what we're talking about and jump into the topic that's presented by the slide. Keeps us on the same page, so to speak. So my objective is to describe what pain is, the different ways to treat pain, focusing on the pharmacological areas because I am a pharmacist, moving through the different forms of pharmacological pain down to and including opiates, and then going into how we got into the mess we are today with the addiction to opiates, and possibly some remedies that you can do on a personal level to mitigate some of those problems that might happen with the opiates in your own life or around you and surrounding you, because it's around all of us. So let's start out with this first slide. What is pain? It's an unpleasant sensory and emotional experience associated with the actual or potential tissue damage. So nothing somebody wants to have happen to them. So why in the heck does your body want to have this? Well, it protects you. It alerts you to a problem in the body, such as putting your hand in a furnace. It protects your body from further injury because you activate that flexor motor neuron, which generates you to quickly withdraw your hand from the furnace or whatever is causing the problem. It also aids in healing because you don't go and continue the activity that's inherently causing the pain. I just wanted to relate a story that just happened to me. I just moved out of a house and back onto a property I have up in Orick. I was cleaning the windows outside. I had my ladder set on the ground, and it was one of those indoor ladders. It had very small legs, and that leg went down into a gopher hole projecting me sideways from it wasn't that high, maybe 3 feet, but boy, at 61, when you land from 3 feet off the ground, I hit with a thud. And all those flexor motor neurons went off, and it told me just to lay there. And again, it forces your body, pain forces your body to react to what's happening. So the best thing I could do was lay there for 15, 20 minutes and self-assess what was happening in my body. And I'm sure we've all had that sort of thing happen to us, such as this. As a 7-cat owner myself, I've certainly been bit by a kitten like this, and hopefully most of you have had this happen, mostly, and hopefully you haven't thrown the cat across the room in that sensory motor neuron response, because that wouldn't be good for the cat. So we can also overcome pain and deal with it. Just as a kind of a, whoops, I'm one ahead of myself. No, somehow a slide disappeared, but that's okay. So prior to this, nociceptors are off, that's right there on your fingertip in the picture, often referred as your pain receptors, are free nerve endings. In other words, that's the end of the nerve, located all over the body, including your skin, muscles, joints, bones, and internal organs. The main purpose of nociceptors are to respond to damage to the body by transmitting signals to the spinal cord and brain. So there you see it, the pain occurs, whatever it may be, in this case a flame, that nociceptor transmits an impulse up to the spinal cord, where it travels up the spinal cord, and my picture's in the way, but it's up the spinal cord to the brain, to the ascending pathways, travels through the spinal cord to the medulla. They can also set off by neuropathic pain, that's nerve pain, damage to peripheral nerves, spinal cord, or brain itself. Thoughts, emotions, circuitry can affect both ascending and descending pain pathways. And that's why there's things called psychological pain, which originates in the brain, but it's felt as very real pain. So if pain is an important part to our life in general, why would we want to treat pain? Well, pain is part of life, but it doesn't have to rule our life. It negatively impacts, it has a negative impact on the body. It can decrease, well, it decreases negative impact on the body. It decreases complications that can occur because of the pain, because you either pull away or you immobilize yourself so you don't cause more pain or more injury. Decreases the likelihood of chronic pain development, and it improves the outcome. Pain causes us to increase the speed of recovery, decreasing the length of stay in hospitals, that sort of thing, decreases the healthcare costs. To make the period of disease accompanied by the pain less unpleasant, that's why we want to treat it, and it increases productivity and quality of life. I'd like to tell another story here on a personal note. I remember when I was about 21 years old, still naive to everything. I had pain, I can't remember why. I went to the doctor gave me Percocet, which is a very strong oxycodone pain reliever. He gave me no counseling. I went and picked it up at my pharmacy. He gave me no counseling. I guess they thought a 21-year-old should know something about Percocet. I was totally naive. So what did I do? I took a dose and I drove. Saw some friends playing soccer. I was feeling really good. I went out there and played soccer hard, slid and did everything you do when you're playing soccer. And I felt a little more pain, so I took another one, probably about an hour later, which is getting a little bit much for somebody who's completely naive to an opiate. Then what's a guy do on a Friday night at 21 years old? I went to a party, of course, drank a couple beers, and woke up the next day feeling pretty crummy. Miraculously still alive. So although they do work, counseling, remember to get your counseling from your pharmacist whenever you get on pain meds or anything else. We are part of the healthcare team. But main groups of pain treatments. So 1 in 5 people suffer from moderate to severe chronic pain. Chronic pain being something that goes on and on. Acute pain being the thing where you're burning your hand and you feel it right away. So 1 in 5 people suffer from pain. That's a huge number of people within the world. So what are those groups? There's psychologic ways of treating pain, and that would be through counseling, and that's a very important step in treating pain. There's physical ways of treating pain, such as stretching, exercise, immobilization through casts, that sort of thing. There's interventional, such as chiropractics or acupuncture. There's surgical ways. You can remove cartilage, you can put in prosthetic joints, that sort of thing. There's peripheral ways of treating pain, like massage therapy. There's central ways of treating pain. There's gynostomy, leucostomy. The most common ones we know is like a nerve ablation, where they actually burn a nerve so it does not transmit signals anymore. You can have implanted neurostimulators like TENS units implanted, and of course pharmacologic, which is drugs. This is the main focus of my talk today, though let me dispel a common fallacy. Providers put people on medications. Pharmacists take people off medications. So I know people think I'm a drug pusher. I'm actually not a drug pusher. I remove people from pain, from meds. Not to say I won't give you them, don't worry. So pharmacologic treatment of pain, that's medications. So main pain groups, there's paracetamol, and we'll get into what that is, Nsaids, muscle relaxers, neuroleptics, antidepressants, and opiates. Paracetamol is acetaminophen. So a very simple structure. I like to show the chemistry of it because I like the fact that it's just a real simple molecule. Acetaminophen, its mode of action is not clearly understood, but it's believed that it acts mainly in the brain on a serotonergic pathway, which is the same one they use. A lot of the antidepressants work with serotonin as well. It modulates the amount of serotonin released in the body. And it's only weakly acts out in the body as an anti-inflammatory. You have to take quite a large dose to get any anti-inflammatory from acetaminophen. So primarily it's not used for that purpose. But it's the go-to because it has so few side effects. A lot of people get scared of acetaminophen though. They're thinking liver damage, right? And that's very real, but as long as you stay within the guidelines, it's metabolized in the liver where it's conjugated to what's written on the glucuronidation is one way of getting rid of things, sulfate, and that 10% also done by what's called a cytochrome P450 into this bad stuff. I'll just read the acronym NAPQI. And under normal circumstances, NAPQI is rapidly detoxified and eliminated in your urine. But potentially it can be very hepatotoxic. That's hard on the liver, and especially increases with significant overdose. This is why when we tell you don't go past 3,000, maximum 4,000 milligrams in a 24-hour period, you must stay below that. There's two pathways, and the reason being there are two major pathways by which acetaminophen or Tylenol is metabolized. Under the 3,000 milligrams, almost 100% of this goes through the glucuronidation pathway, which is totally detoxified, you pee it out, no problem. But if you go beyond that 3,000, especially 4,000 milligrams in a day, and that, by the way, is 3,000 is 6 extra strength 500 milligram acetaminophen over the counter. Of course, 4,000 would be 8 of those. So you never want to go past that number because then you start producing too much of this NAPQI, which then can quickly toxify your liver and cause major damage. Under 3,000, you're bueno. Over 3,000, you start getting into that danger zone. So just stay low. Now, what's the problem? Why do people get there? It's so simple. Just don't take more than 6 in a day. But you got to remember, acetaminophen is included in a lot of different pain medications. A lot of your pain and your cold medications have acetaminophen in them. A lot of your headache medications have it. A lot of your narcotics, your opiates have it. It's in Percocet, Norco, Vicodin. A lot of other medications also include acetaminophen. So when you start overlapping those type of medications, you can quickly see why you might get past the 3,000 milligrams. So be very careful that you get your counseling before you start taking pain meds, and make sure that acetaminophen, or a lot of times it's abbreviated APAP, is, if it is in those, that you add up what you are taking and don't go beyond 3,000 milligrams in a day. Any questions on that? Okay, I'll move on. The next in the step therapy would be non-steroidal anti-inflammatory drugs, or better known as Nsaids. The most common, oldest one used in cultures from way back is aspirin, or salicylic acid, is found in all kinds of herbal remedies and things like that. But that also is another Nsaid is ibuprofen, which is Motrin, Advil, naproxen, naproxen, Aleve, diclofenac, which is Voltaren, etodolac, Lodine, indomethacin, which is Indocin, meloxicam, Mobic, and Celebrex, one of the newer ones, or Celecoxib. So how do these work? They work on something called prostaglandins. Prostaglandins are produced in the kidney, and they're a family of chemicals produced by cells in the body and have several important functions. They promote inflammation that is necessary for healing. But as we know, inflammation, swelling, results in pain and also fever. They support blood clotting functions, so they make your blood clot. Remember, that's why we take aspirin when we have a problem with that, to decrease the amount of clotting. And they also protect the stomach lining from damaging effects of the acid produced when you eat. So prostaglandins are a good thing. So why do we take Nsaids to block them? Well, as we said, swelling hurts, right? You get swelling, it tends to hurt. So if you can decrease swelling, you decrease pain. The other side effects are not ones that we definitely really want to get into as far as blocking. But, so we'll go to the next slide here. Prostaglandins are produced in the body cells by an enzyme called cyclooxygenase, or what we call COX. There are two types of COX enzymes, COX-1 and COX-2. Both of these enzymes produce prostaglandins that promote inflammation, pain, and fever. However, only COX-1 reduces prostaglandins that support platelets and protect the stomach. So the COX-1 is the one that protects you from getting ulcers and causes your blood to the platelets to block any kind of bleeding. Non-steroidal anti-inflammatory drugs block COX enzymes and reduce prostaglandins through the body. As a consequence, ongoing inflammation, pain, and fever are reduced. Since prostaglandins that protect the stomach and support platelet and blood clotting are also reduced, Nsaids can cause ulcers in the stomach and can promote bleeding. So this slide shows, it starts on what they call arachidonic pathway, and COX-1 and COX-2 are the two enzymes produced. Don't look at the red for a moment, because that's the block of them. You go through and you look at COX-1 is primarily on the left hand for me of the screen. So the gastric production, hemostasis, that's the platelet production, and also renal function, causes how much we can filter. COX-2, on the other hand, is more involved in the pain and inflammation side. So if you take an Nsaid that blocks both COX-1 and COX-2, biggest perpetrator there would be aspirin, acetaminophen, aspirin or what am I saying, Motrin, Aleve, those guys. You get both blocked. So you do get the pain relief, but you also leave your stomach bare to the acid production. You also increase the possibility of bleeding because you don't have the platelet function, and you also decrease renal function. If you get an Nsaid that primarily blocks only COX-2, you overcome the gastric hemostasis and renal problems, and you get primarily the pain and inflammation only. So that is was the goal for a long time of how can we get an Nsaid to do only that? Well, here is a graph showing you the most common Nsaids out there and how selective they are to COX-1 and COX-2. On the left-hand side, we have those favoring COX-1. On the right-hand side, we have those favoring COX-2. The line down the middle is a 1-to-1, so equally blocks COX-1 and COX-2. So the farther we can get the ratio to the right-hand side or to COX-2, the better. Well, most of those guys aren't even on the market down there at the bottom of the graph. The first one that is available is Celecoxib or Celebrex. And so if you are going to be on chronic pain relief using non-steroidal anti-inflammatories, Nsaids, Celebrex is probably going to be your best choice. And now that it's generic, it's fairly cheap now. We certainly carry it at UIHS. It would be a better one to be on than, say, ibuprofen, naproxen. But everybody has their favorite out there that seems to work best for them. But I would suggest that if you're on long-term therapy, anything over 2 weeks, then you ought to be getting on something that has less COX-1 inhibition. Meloxicam or Mobic is a very popular one also. The next topic, the next pain relievers we'd like to go into are muscle relaxants. Muscle relaxants or muscle relaxants are medications used to treat muscle spasms and muscle spasticity. They work right on the nerve endings in the muscle. So muscle spasms or cramps are sudden involuntary contractions of muscle or groups of muscles. They can be caused by too much muscle strain and lead to pain. They're associated with conditions such as the lower back pain, neck pain, and fibromyalgia. Muscle spasticity, on the other hand, is the continuous muscle spasm that causes stiffness, rigidity, or tightness that can interfere with normal walking, talking, or movement. Muscle spasticity is caused by injury to parts of the brain or spinal cord involved with movement. Conditions that cause muscle spasticity include multiple sclerosis, cerebral palsy, and amyotrophic lateral sclerosis, ALS. Hopefully none of you have those, but much more involved chronic pain. But the standard pain that we all get from working out too hard or working too hard one day is more muscle spasms, and we can treat those very well with all kinds of things, but muscle relaxants help there. Unfortunately, muscle relaxants, as with any medication, go throughout the entire body and don't only relax the one muscle that you're after, but relax your entire body. And that's why you get the fatigue and side effects that you get with those. They're thought to work by causing sedative effect or preventing nerves in your muscles from sending pain signals to your brain. While muscle relaxants can be used to treat muscle spasms, they have not been shown to work better than Nsaids or acetaminophen. In addition, they have more side effects than Nsaids and acetaminophen. The most common side effects with muscle relaxers are drowsiness, headache, dizziness, nervousness, reddish purple or orange urine, lowered blood pressure upon standing. Stand up, you get dizzy. Typical muscle relaxants available on the market are methocarbamol, cyclobenzaprine, carisoprodol, metaxalone, tizanidine, baclofen. Also use benzodiazepines, which are a different class, but we use them as muscle relaxants, chlorzoxazone, and orphenetrine. Next class we'd like to talk about, which had a real breakthrough in pain relief, are the neuroleptics, gabapentin and pregabalin, Neurontin and Lyrica. So the nice thing about these, they cause very few side effects, but they don't work for everybody. So these can provide good levels of pain relief to some people with post-herpetic neuralgia, which is zoster or chickenpox, zoster pain, and peripheral diabetic neuropathy, the pain that diabetics tend to get, people with diabetes tend to get from in the nerve endings in their feet and their hands. Evidence for other types of neuropathic pain is very limited. The outcome of at least 50% pain intensity reduction is regarded as a useful outcome of treatments by patients. And the treatment and the advancement of this degree of pain relief is associated with important beneficial effects on sleep, interference, fatigue, depression, as well as quality of life and function at work. But as I said, they only work for about 3 or 4 out of 10 people that use them, because not all pain is neuropathic pain. So what I generally counsel people when they're started on gabapentin or Neurontin is start out low, increase the dose slowly, but when you get up to the maximum pain or maximum doses of 2,400 to 3,600 milligrams a day, and it's just not doing anything, well, talk to your provider, and you probably don't have the type of pain that works with this, because over half the people it doesn't work for. But for those people it does work for, those 3 to 4 out of 10, it works wonderfully with very few side effects. So I do encourage you to try it, but don't stay on it for more than a couple months if it's just not doing anything for you. The next class, and I would say in a step, if the neurologics, gabapentin, pregabalin are not working for you, then the next step would be to try an antidepressant. So duloxetine is kind of our go-to. It works both on serotonin and norepinephrine. And again, the same thing, it doesn't work for everybody, but I would suggest that if the neuroleptic didn't work, then an antidepressant might be the next step, and you want to maximize that dose as well. If that's not working, tricyclics, the old antidepressants like amitriptyline, have a pretty good pain profile as well, but the side effects of those tend to keep people from them, which is drowsiness. They're used to treat depression and anxiety, so they do have a dual purpose as well. In addition to these, they're used to help relieve nerve pain in people with diabetes or ongoing pain due to medical conditions such as arthritis, chronic back pain, or fibromyalgia. They tend to work, if you want to classify them, they tend to work more on that burning pain. So that brings us to opiates, which, well, we'll go on with it. In some terminology, the old terminology is narcotic. This is kind of an obsolete term used to refer to what is now called an opioid. Current usage is primarily in a legal context to refer to a wide variety of substances of potential abuse. Opiate refers to all naturally occurring substances with a morphine-like property, the stuff that you get from an opium poppy. Opioid is a more general term used to include all these synthetics that go along with that have opiate-like effects on your body. So some opioids, I'll list them here. Codeine was kind of the oldest one, heroin's your oldest. Fentanyl is the one that's all the rave nowadays. It's causing so much problem, getting laced in with heroin and being produced in the back corners of people's houses. Hydrocodone is the most common pain reliever prescribed. That's your Norco, or hydrocodone with acetaminophen is your Norco, and hydromorphone, merperidine, methadone, morphine, oxycodone, tramadol, and then also the buprenorphine and buprenorphine with naltrexone, which is used in the medication-assisted treatment programs nowadays to help people get off of these things. I'll go into these a little bit more here. So if you compare their strength to hydrocodone, the most common one out there, Codeine's only about 1/7 as strong as hydrocodone. Fentanyl, look at that, 50 to 100 times as strong. That's why we get in such problems with these drugs when people start to abuse them. They're so strong, just a little bit more than you're used to can send you over the edge. I have question marks by heroin because, of course, heroin gets stomped on, cut. You never know exactly what you're getting on the street. It's not available as a pharmacologic agent. You can't buy it legally, in other words, not in this country anyways. And it's also commonly mixed with other things such as fentanyl, and it can be much stronger than you might think. Then hydrocodone by itself or mixed with acetaminophen. Of course, that's 1-to-1. There's hydromorphone, which is dilaudid, a lot of times used in hospitals as an injectable to get you out of pain. Demerol, which is not really available much anymore. There's methadone, which you might be more associated with as a treatment mechanism for people in medication assisted treatment programs. It just gets people away from injecting an opioid and therefore less passing of other diseases. There's morphine, which is 1-to-1, oxycodone, which is 1.5 times as strong as hydrocodone. There's tramadol, which is about 1/10 as strong, but less addiction potential. And of course, buprenorphine and buprenorphine plus naloxone, which is Subutex and Suboxone, which are 30 times as strong, but there's a limitation there I'll talk about. They do use it in MAT programs or medication assisted treatment. This is a primary one they go to because it doesn't give you the high as much, and also it has an agonist-antagonist component to it. So at lower doses, it's an agonist, meaning that it actually works on the receptor and causes pain relief, causes all the things that a morphine analog would. But as you increase the dose, it actually becomes an antagonist and stops working. So there's there's a maximum dose you can go to, so it's very hard to abuse. So all opioids are chemically related and interact with the opioid receptor on the nerve cell in the body and brain. Opiate pain relievers are generally safe when taken for a short time period and as prescribed by a doctor or a provider, I should say. But because they produce euphoria, in addition to pain relief, they can be misused, taken a different way or in larger quantities than prescribed, or taken without a doctor's prescription. Regular use, even as prescribed by a doctor, can lead to dependence, and when misused, opioid pain relievers can lead to addiction, overdose incidence, and death. There's 3 main opioid receptors in the brain, and this is important. The first is responsible for analgesia, pain relief, and physical dependence. The second is responsible for respiratory depression, trouble breathing. The euphoria, that gives you the high, decreased gut motility, that causes constipation, things don't move through your body as quickly, somnolence, sleepiness, and physical dependence. The third is responsible for that flushing reaction. If anybody's had a big dose in the hospital or whatever, you can get red in the face or see people get red in the face. That's the vasodilation, or blood being forced out to the outer blood vessels in your body. So the 3 different receptors cause different types of problems in your body. The biggest problem with chronic use of opiates is constipation, and constipation is not to be taken lightly. You need to go to the bathroom, people. And if you can't, you can get compacted, and that's a whole nother problem that people get into that are on chronic pain, opiate pain relief, chronic meaning long-term. The other things are cardiovascular. It can cause hypertension, cause that peripheral edema we talked about, where you get all the blood forced to the outside of your body. And what's on my page there, and I'm getting behind, I'm turning my pages, sorry. Here, it increases your cholesterol, believe it or not. And central nervous system, that means your brain, basically. Yeah, it causes headache, pain, way behind. chills, sedation, anxiety, insomnia, so it can actually keep you awake, dizziness, drowsiness, fatigue, depression, falling. You get into problems with, especially in the elderly, with falling and lethargy, just not wanting to do anything. Sorry, I got away on more adverse reactions. Here we go. So on your skin, you can get sweating, you can get rashes. As far as metabolism goes, you get dehydration, hot flashes, decreased potassium, increased cholesterol, gastrointestinal, that's your stomach. You can get vomiting. That's one of the most common ones. I tell people, you got to take it with food or else you're probably going to throw it up. Dyspepsias, acid reflux, gastroenteritis, same sort of thing, acid problems and stomach problems. Abdominal pain, usually that's the constipation. You can get also diarrhea, but generally diarrhea is a constipation block that everything's leaking around. You can't stop the leak. You can decrease appetite, xerostoma, dry mouth, abdominal distress, gastrophoresis, that's getting the reflux disease. And you can also have increased urinary tract infections. Look at this, it just goes on and on, doesn't it? Have I convinced you not to take these things? You get bruising. You can, more commonly, you get infections like influenza. In today's day and age, we don't need that. Neuromuscular and skeletal, you can get back pain actually from using this. Muscle spasms, tremors, arthritis, bone fracturing, injury to the joint, sprains, all kinds of problems with musculoskeletal issues. You can get tinnitus, which is ringing in the ears, bronchitis, nasal congestion, upper respiratory infection, cough, and dyspnea, because it decreased remember, one of those receptors was decreased your ability to breathe. In other words, you lose the function to automatically breathe, and you actually have to force yourself to breathe. Some people have this so bad they can't even touch an opiate because they stop breathing right away. But at higher doses, this is why people tend to die with overdoses. They stop breathing. Interactions with other substances. Of course, we all know you don't take opiates with alcohol, but people seem to like to do that. I guess it enhances the both, and I found that out as a 21-year-old without knowing it. So you get increased drowsiness and dizziness, and increases concentrations of hydrocodone in the body to potentially high levels. This is especially important with extended release formulations. So you don't want to drink alcohol when you're taking an opiate pain reliever. And some antidepressants and other anticholinergics, which are things that make your dry mouth, like antihistamines like Benadryl and things like that. You don't want to take them with that because that increases the toxic effects of both of them. And it increases your constipation because you're drying out, and also stops you from urinating and going pee. You don't want to take them with amphetamines, the things that supposedly speed you up. They can increase the effects of both of those and potentially leading to overdoses. Believe it or not, you're not supposed to take it with cannabis. Increases drowsiness and dizziness. Benzodiazepines, this is a really major one. That's your Xanax, your anything with, what am I thinking? We'll get into those in a bit, but you don't want to take them along together because concomitant use, you can get severe dizziness, drowsiness, and potential to stop breathing. So don't take them within 6 hours of each other. So anything ending in PAM, so lorazepam, alprazolam, those guys. Also strong liver enzyme inhibitors, both of these things, so that if you inhibit these liver enzymes, it inhibits the breakdown of these compounds. So if you inhibit these two cytochrome enzymes in your liver, you're going to it'll decrease the removal of the morphine from your body. Therefore, you get higher and higher levels. So some of those things are like antifungals. A lot of people get put on a pain reliever, but they're also on diflucan, which is an antifungal usually used for vaginal yeast infections. Well, within a 24-hour period, you can quadruple, even go higher, the levels of the opioid in your body by taking that antifungal. So be very careful and get your counseling again when you go to the pharmacy. Try to get all your medications from one pharmacy so they can see what you're on and warn you about possible interactions with your drugs. Also, some of the antivirals used in AIDS and that sort of thing, and also what are called proton pump inhibitors that are some of the most common medications out there used, like the omeprazole, that's Prilosec, or Nexium, esomeprazole, or Protonix, those sort of things. Just be careful of those and concomitantly use it. But especially omeprazole tends to have an interaction there in reducing the removal of the opiate from your body, so you get higher and higher levels. Statins, a lot of us are on cholesterol lowering drugs called statins, Lipitor, Zocor, anything ending in statin, atorvastatin, simvastatin, and some antibiotics, though not as common, clarithromycin and metronidazole. Interaction with other substances. Now, Trexone, well, that's what we give to people to get them off of this, right? It competes for the opioid receptors in the brain and blocks the morphine, the effects of the morphine compound. So it knocks the morphine, the hydrocodone or whatever thing is on board, and it competes for that mu receptor. Naloxone, that's the one we give to rescue people. And that blocks, or actually permanently knocks off. It doesn't just compete, but it's like Goliath and the fly type thing. It being Goliath, it knocks everything off and it takes over that receptor site. Also avoid using this with Ambien or Zolpidem, a real common sleep medication, not within 6 hours of each other, because you get dangerous levels of drowsiness and breathing problems. So why a lot of us are here is because, and why this coalition, the opioid coalition, is formed, is because there's a huge problem in the United States now with the amount of opiates on the open, not the open market, but the illegal market. And legal, most of it comes from the legal market and gets diverted into the illegal market. So how do we get here? So it all happened, well, it's been around forever, right? I mean, people have been using opium since way back in China and whatnot. But as far as the medical history here, they weren't used all that much up until there, about January 10th, 1980, there was a hospital physician named Herschel Jick, and he published a 2-paragraph, it wasn't even an article, it was just an ad-off at the end of a major medical journal. Just 2 paragraphs, and all it said was the gist of it is very rare for people to become addicted to narcotics when treated for a 1-week period in a hospital setting. So, of almost 12,000 patients treated with opiates while in the hospital before 1979, only 4 developed addiction. There was no other data given as to how long, what dose, or the ailment the opiate was given for. This became known as the Portnoy-Jick landmark study after it was resurrected by Dr. Portnoy in 1987. It became a much cited reference that less than 1% of patients started on opiate painkillers became addicted, even though these patients were in a hospital stay of less than 2 weeks and were not discharged on narcotics. So this is this landmark 2-paragraph study. Most people didn't even read it, in other words, it was just cited. The mantra being supported by this one paragraph or 2 paragraphs, addiction rarely occurs in opiates when opiates are used to treat patients in pain. Addiction occurs only in people using opiates for pleasure. That became what drug companies and everybody else chanted. Giving a tablet for pain was much simpler and cost effective. Over 1,000 multidisciplinary pain clinics existed before 1988. By 1995, only 85 existed. insurance companies stopped reimbursing these clinics and universities stopped teaching alternative therapies. In other words, we used to use all the other painkillers. All of a sudden, we switched away from psychological, counseling, from psychotherapy, and from massage therapy and chiropractic, and everything was diverted to pharmacologic opiate pain relief. Treatment increased the dose of opiates until the pain resolves. Purdue Pharma, Johnson & Johnson, and other producers jumped on the bandwagon, pushing this information on pain specialists and general practitioners. They patented and produces stronger and stronger opiates, making billions of dollars. We kind of all know that story. Reality check. Americans are about 6% of the world's population and consume about 80% of the opiate pain relievers in the world. Incredible. Before I go here, so as you know, once this was found and providers started decreasing the amount of pain relievers available on the market, that's when things switched to the more illicit forms. And where we've gotten to today with the fentanyl-laced heroin and whatnot is all a factor of people becoming addicted in the 90s and 2000s, and then having their pain medications withdrawn from them once providers found out that, they were given incorrect information, and then people were left kind of in a quandary because they were addicted to these meds, but the doctors weren't willing to give them out as much, and in steps illegal drug usage with heroin and things like that. And these amazing story told in a book called Dreamland. If you want to really look at the history of addiction and how this all happened, look up a book called Dreamland. It's an amazing story about the proliferation of addiction in America. But so then just recently, a study came out to show that, so what do? What oral analgesic combinations are effective in reducing the pain of an acute, just happened, extremity injury in adults in an emergency room? So the bottom line they found was, in adults presenting to emergency department with acute extreme pain, severe enough to warrant radiologic investigation, in other words, they had to x-ray and see if they had a broken bone or internal bleeding or whatnot, ibuprofen plus acetaminophen, plus Tylenol, was equally effective in reducing pain intensity at 2 hours compared with 3 different opiate acetaminophen combinations. So more effective than Vicodin, more effective than Norco, more effective than Percocet at reducing pain after 2 hours. Now, you come into the hospital, what's the first thing you want? You want pain gone now. And that's where an opiate comes in. Get the opiate on board, give them the acetaminophen and ibuprofen. 2 hours later, that's all they need, according to the study. The only thing more effective was 40 milligrams of oxycodone. Anything below that, they found that the combination of acetaminophen and ibuprofen was a stronger pain reliever. And I've cited the article there. So how have we effectively, what have we effectively done at UIHS to help with this problem? What are our policies towards dispensing opiate medications? And this isn't unique to us. We follow these general guidelines. We definitely customize them to us. But generally, don't assume a controlled medication is required for acute or chronic pain. Always provide appropriate adjunct therapies such as physical therapy, counseling, acupuncture, whatever, and non-controlled medications prior to considering a controlled substance. For mental health indications, because that is real pain, the daily use of short-acting benzodiazepines is not considered appropriate. For clients with daily anxiety, the use of non-benzodiazepine treatments, such as things like SSRIs, that's your Prozac, those sort of things, or buspirone, which is a it's for anxiety as well, should always be considered primary therapy, with the use of longer-acting benzodiazepines as adjunct. In other words, don't use a short-acting benzodiazepine, use something long-acting, less cause for abuse. In clients requiring daily benzodiazepine, despite adequate use of antidepressants such as SSRIs or other non-controlled medications, psychiatric consultation is recommended. So we always want to get you in with behavioral health if you have chronic pain. It's because of the use of the brain, mind over matter, is amazing. Medications with strong, high risk for abuse, such as OxyContin and Soma, should be avoided. For clients at high risk because of personal or family history of substance abuse or psychological conditions, perform a baseline urine toxicology. So get a urine screen and consider running what's called a cures report. In other words, we look at your past usage. It's all, don't worry, you know, everybody's watching you, don't worry. They'll know exactly what you're taking out there. If a controlled medication is warranted, prescribe the smallest amount of the medication for the shortest period. In other words, Partnership Health Plan recommends limiting to 3 days. Limit acute prescriptions to no more than 20 tablets. Avoid filling acute prescriptions for controlled substances. Ask clients requesting refills to return for reevaluation. And then also provide the client with a copy of our controlled medication agreement. So we're both on the same page. So the provider and the client know the goal to their pain treatment. That often will help out with the anxiety of whether or not I'm going to get a refill or not, because you go back to the agreement, you know, everybody's on the, it's up and up, what is considered appropriate therapy and what the duration of that therapy is going to be. Initiating controlled medications. Prior to initiating controlled medication, ensure that the appropriate diagnosis is entered. Get the tox screen done, run the cures report. If the client is long-acting opiates, avoid using breakthrough medications. In other words, if you're on OxyContin, IR, or ER, that's the long-acting, twice-a-day type thing, you limit how much of the breakthrough medication, the immediate acting, that you send out. You don't just give across the board huge amounts. Avoid the use of multiple controls, and provide the client with a copy of our controlled medication agreement. And then lastly, methadone proposes significant health increases and should not be the first choice of long-acting medications required. If methadone is to be initiated, a base because of the heart issues, a base EKG must be performed. Do not initiate methadone with, and those are medical terms. I might zip on past this because I'm probably boring you. This is all on our website if you need it. So what can you do as an individual out there in the real world? You take action. It's up to all of us to take action against medication abuse. The best place to start is in your own home, by storing medications safely and securely, and by taking your by talking with your kids about the dangers of medication abuse, medicine abuse. Now, at our pharmacy and through our clinic, you can get one box per individual, a lockbox for your medication. And I highly suggest, if you have any medications, because they can all be dangerous, not necessarily abused, but dangerous if somebody takes too many of them, locking up your medications. That's primary, or at least keeping them where kids can't get to them. And if you can't avoid it, make sure you have a child-proof lock on top of each bottle. Mind your medications. 2/3 of teens and young adults who report abuse of prescription medication are getting it from friends, family, or acquaintances. Make sure that young people in your life don't have access to any medications in your home. Follow these 3 steps to monitor. Secure and properly dispose of unused and expired medications and over-the-counter medications in your home. There's no reason to have a medication cabinet full of old bottles of medications with 2 or 3 or 10 or 12 medications at the bottom. If you're not taking them, if you're beyond that need, get rid of them. Please don't flush them down your toilet though, because that just goes into the environment where the fish get high. Let's take them to a medication disposal site. Almost every major pharmacy out there today has a drop box where you can safely put your medications in and they will be destroyed in a sustainable, safe way. Here at UIHS, at least at Pottawa, we have a medication disposal bin. Bring them in there, we don't mind, just throw them in there. If you're at one of our outlying clinics, we have bags you can use that you can put those medications in and send them to a disposal site. Please get those things that are unused out of your home. That's the primary thing you can do to overcome abuse. Step 1, monitor. How aware are you of your prescription medications currently in your home? Would you know if some of your pills were missing? From this day forward, make sure you can honestly answer yes to that. Start by taking note of how many pills are in each of your prescription bottles or pill packets and keep track of refills. This goes for your own medication as well as your kids and other members of your household. If you find you need to refill your medications more often than expected, it could indicate a problem. If your child has been prescribed medication, be sure you control its use by monitoring dosage and refills. You need to be especially vigilant with medications known to be addictive and commonly abused, such as opioids, benzodiazepines, and stimulants, those ADHD medications. Not saying you may not need them, just make sure you're monitoring them closely. Make sure your friends, parents of your child's friends, neighbors and relatives, especially grandparents, are also aware of the risk. Encourage them to regularly monitor the medication in their own homes as well. Step 2, secure. Approach securing medications in the same way you would other valuables in your home, like jewelry or cash. There's no shame in helping protect those items, and the same holds true for your medications, your medicine. Remove prescriptions from the medication cabinet and secure them in a place only you know about. If possible, keep all medications, both prescription and over-the-counter, in a safe place, such as a locked cabinet your teen cannot access. Sorry to be hard on teens if you're out there. And most teens are just wonderful. I've had 3 of them. Step 3, dispose. Safely dispose of expired or unused medications is critical to helping protect kids, family, and home. It also helps decrease the opportunity for visitors in your home, like your kids, friends, to abuse medications. The ideal way to do this is by participating in a drug-safe disposal program, either a drug take-back day, an ongoing program in your community, a drug deactivation bag. There's things you dump it into and it deactivates in a chemical compound in the bottom, or a drug mail-back program. So there's a couple websites you can go to. Visit American Medicine Chest Challenge or the DEA website for places you can dispose of things. And that's pretty much all I have to say about this. Any questions or comments?
I'm not seeing any questions yet, but we'll give it a few minutes so people can leave any. I did want to ask, is there any, and just thank you for presenting. It was very informative, and I appreciate, learning from someone who directly works with these things that we're talking about constantly, but it's nice to actually hear some, direct opinions about it from someone who works with them. So would you like to leave everyone with just some last information, last words?
Yeah, I'd just like to say that medications are very important. They're a major part of the therapy, Western medicine that we use here in the United States and throughout the world for that matter. So I'm not dissing on any medications. I'm also not dissing on people's pain. I know there's very severe chronic pain out there, and some of it does require opiates. So there is a use for these medications out there, but you have to agree with the problem that the United States is in, and that's what we're trying to focus on here is, if at all possible, avoiding the use of these pain medications and realizing that there are fantastic alternatives that work for pain that are far less dangerous and maybe far more effective. And that's the biggest note I want to send out, is that I'm not trying to say that pain is not out there. It really is, and you do want to deal with it because it's a quality of life issue. But if we can deal with it in a way that is safer for you and everybody around you, then that's a good thing.
Wonderful, thank you. We do have one question in the chat. They asked, how accurate is the expiration date of pharmaceuticals? Do they really lose their potency that fast?
The legal answer is throw it away after that date. But the actual answer is those are fairly arbitrarily put on a medicine because the FDA has required that all things have an expiration date. I mean, you look at your bottle of iron. Iron has an expiration date. Iron will last for thousands of years. So why put an expiration date on your iron? Other medications, they have done studies to show that, I mean, they have to do a study to show how fast things degrade under certain conditions, but they do put those under fairly extreme conditions and see how fast they degrade. So stored safely, they will at least get to the date. Well, actually, I'm sorry. We are mandated as pharmacists to put a year from the date it was dispensed on all medications as the expiration date. That's not the date that the actual bottle says. I can store them on my shelf to whatever it says on the bottle, but I'm mandated by the FDA out there to actually put 1 year from the date I dispensed, because we don't know how you're treating your medications. Are you throwing them on your dashboard in the hot sun? Are you storing them in your medicine cabinet with the top off and they're getting exposed to moisture and things like that? Are they light sensitive? We just don't know. So we put a year on them. So I would say any medication that you're given, well, you should be using it up within that year. If you're not, say it's an over-the-counter medication, then I would still dispose of it, but I'm not going to tell you stored properly that it's actually going to be ineffective after that date. The only issue you get into is some medications do actually become toxic over a certain period of time. Erythromycin is a classic example of that. We don't use that as much anymore. Tetracycline is another one. So certain antibiotics can become toxic when stored too long, so be very careful of that. You can look all those things up on any poison control website. The two websites that I gave at the end, American Medical Association would have it, or the Board of Pharmacy websites would all have that information on which chemical compounds become toxic over time.
Wonderful, thank you. With that, I would love to ask, to kind of piggyback on that, are there any other resources that you recommend for people if they're, you know, just more curious or have any other questions in the future and want to research it a little more?
Well, you can pretty much research any med on the internet by Googling it, right? Of course, you'll get everything under the sun there, but PubMed is a good place to go. We, of course, have Facts and Comparisons, I believe, has a public site. That's a very good one. Those are the ones that I would most, we use Facts and Comparisons in my pharmacy.
Awesome. Well, thank you so much. And if anyone has any questions, you are still welcome to leave them in the comments even after this video is over, and we can try and get them to Tim, or we can try and answer them ourselves. But yeah, we will have this entire presentation recorded on our YouTube also, if you want to watch it further or recommend it to your people who may be interested. So I just want to say thank you to our presenter. You did fantastic, and I learned so much, and it was so informative. So I really appreciate you being here today.
Thank you. My pleasure.
Yeah. Wonderful. Well, before we get off today, I just kind of want to share some information before we get off. As usual, we are the Wellness and Recovery series. I'm Malaya Florendo, trainer with Orick Safe Del Norte. And we are on week 3 of the Wellness and Recovery series, last day of the week. And we just want to thank everyone who participated for the past, 3 weeks, but also this week has been very informative and wonderful. So we appreciate everyone participating. I just want to say thank you again to our presenter, and again, this will be recorded and put on our YouTube page, the Orick Safe Del Norte YouTube page. So if you would like to check it out in the future, you're totally welcome to, and recommend it to anyone. Very informative stuff. So I think it's important for everyone to, get educated in this aspect as we're doing this work. So thank you again to our presenter. And we want to remind everyone, as the Wellness and Recovery series goes on for the next 2 weeks until July 30th, that you can still register for Eventbrite at the Wellness and Recovery series.eventbrite.com. Live presentations will be happening on Tuesday, Wednesday, and Thursday from June 30th to July 30th, including speaker and panel series videos and activities, along with social media campaigns throughout the month. We'll be on Zoom, Facebook Live, and if you want to stay up to date, make sure to register on our Eventbrite, and the updates will be there once you're registered. And if you do register, you get an awesome t-shirt with our graphic on it for the Wellness and Recovery series. So make sure that you register to stay updated. And we just want to remind everyone once again that we still have this Wellness Art Challenge going on until the 27th. And it's a awesome, way to engage ourselves and, really manifest our wellness activities, for ourselves, and mindfulness for our wellness activities, so that we can, remember what they are and practice them. And if you can draw it on this PDF, or put in a picture, or write a poem or a word and input it to us, you get in an entry into our wellness raffle. So make sure that you download the PDF. You can download it on our Wellness and Recovery Facebook page, or if you register for the Eventbrite, it will also be there. Again, just draw in the middle what your wellness activity is. What are things that you do in order to keep your mind, body, and spirit healthy? Take a picture or scan it in and upload it on social media, and use the hashtags #HealthyDelNort, #WellnessChallenge, or email to oricksafedelnort@gmail.com. Make sure you include the artist name and age group. Our age groups are 0 to 5, 5 to 9, 10 to 14, and 14 to 24, and 24 and up is our adults. So make sure you provide that information if you do send it in. We're not judging by your art skills. We just want to know what your wellness activity is. So any medium that works for you works for us. So make sure to get those in before July 27th to be a part of the raffle. And we do have our schedule here for the remaining weeks of the Wellness and Recovery series. We are here in the top week for the 14th to 16th. This afternoon, we're going to be doing another lived experience panel with Yvonne Guido and some youth that will be present. to share their experiences. That's going to be from 2 to 4 p.m. So make sure to tune into that. These are the events for the next 2 weeks, and that we are all filled up. So make sure to join in, still register for Eventbrite, get some information on what's going to be upcoming, and we will have this calendar included on our Facebook page if you want to look at it further. And again, we just want to say thank you to our presenter, of course, and our audience. You guys are wonderful. Thank you for, staying involved, engaging. We really appreciate it. If you want to get some more information for the Wellness and Recovery series, you can check out our Facebook page and the RX Safe Del Norte website and RX Safe Del Norte Facebook page. All the information will be up there, but if you want detailed information, remember to register for Eventbrite. As always, we have an evaluation form at the end of every presentation, and the link is here. We will also include the link in the chat. Oops. We will include the link in the chat so you can all go and fill out your eval form. And every time you enter or fill out your evaluation form, it is an entry into our wellness raffle. So make sure you fill out that form for an entry to the wellness raffle. We have some awesome prizes, some books, a really cool blanket from 7th Gen. We're gonna have, a couple really awesome wellness prizes. So make sure you fill out those evals, because then you get an entry. Just try and fill them out the best you can. They do have a couple good, little questions. So just try and answer it to the best of your ability and for that raffle entry. Again, I just want to say thank you to everyone for joining today. We appreciate having you, and we will see you on Tuesday. So thank you, everyone, and have a wonderful afternoon.